Okay. On behalf of the CAOMS Executive Committee, welcome to our first virtual presentation. I want to express my appreciation for your attendance this evening. I do hope that you and your family are well and are coping with many of the challenges that we face today. To say that we are living in extraordinary times is an understatement. As all elective care has ceased across Canada, many of us are sitting on the sidelines and providing minimal amounts of emergency care. I sincerely hope that all members of the CAOMS are abiding by their provincial guidelines and as well practicing impeccable hand hygiene and physical distancing measures as recommended by the Chief Public Health Officer of Canada. As oral and maxillofacial surgeons, we are in this together. The information regarding patient care during this pandemic is coming at us at breakneck speed. Much of this information is coming from our previous experiences with earlier outbreaks of SARS, MERS, and Ebola. Current epidemics in China and Italy have been the source of new information. It has become evident that routine care of the oral and maxillofacial surgery places our team and us at risk of infection. We are all aware of the challenges that we are faced in sourcing the correct items of personal protective equipment. In providing this presentation this evening, the CAOMS wishes to state that we do not endorse any of the products or concepts that are being presented. We do feel that the ideas presented this evening merit early dissemination to our members and hope that further testing and development will lead to a proof of concept and governmental approval. By no means does this presentation suggest a standard of care. In assembling this presentation this evening, many individuals have been involved and it's vital to recognize them here. We wish to thank both Drs. Caissie and Marchand from Montreal for their efforts and their ideas. Tony Chehade, who many of you will recognize, is our marketing and communications chairman, and he has devoted countless hours to pull this all together this evening. Along with Mr. Stuart McCombie and his team from the McGill University Multimedia Live Events Department, we were able to put together this presentation. We look forward to your kind attention and wish you continued good health.
Great, thanks for that introduction, Kevin. And thank you to everyone for listening to us this evening. It's really nice, and I'm sitting here at my computer, and I'm hoping that there's other people sitting somewhere in their computers from across Canada potentially listening to us. I think, first of all, I'd like to say that this is the first attempt, as Kevin mentioned, that the CAOMS is holding a webinar of this nature. And this arose for two reasons. One of them was in lieu of the fact that, unfortunately, face-to-face meetings and conferences are right now being put on hold. And as many organizations have done, this is our first attempt at moving to a virtual platform to share information with you in a timely manner. The goal of tonight's exercise is to share some current information that some of you may perceive as somewhat controversial. And it's controversial in the sense that, the challenge that we are confronted with and that healthcare organizations are confronted with in mandating or dictating best practices in our clinics is that there's a tremendous amount of data that's coming at us, as Kevin mentioned, and regulations are sometimes changing or modulating in response to that data. So the information that we're sharing with you in exclusivity to our CAOMS members is meant in a pseudo-academic sense. It's not meant to supplant or suggest that you should not be following your provincial guidelines and regulations. I'll just further add that as we go through the discussions and hear the presentations of our speakers, there will be a question and answer period that will follow. I will be asking some fairly intuitive questions to our speakers, and I'll try, when I can, to bring back the conclusions of our discussions back to a comparative to our current clinical guidelines and scenarios. So with that introduction, I'd like to say thank you, Dr. Caissie, for being with us. Dr. Caissie is a specialist in oral and maxillofacial surgery. He's Chief Medical Officer at Dorma Labs and a partner at DentalCorp. He's an active member and surgeon at the Hôpital de Sacre Cœur in Montreal, and he's a fellow of the Royal College of his specialty. He is a clinical lecturer at Universite de Montre, Department of Surgery, and is often invited to lecture at oral and maxillofacial surgery conferences. He's published multiple peer-reviewed articles in the field of nerve regeneration and is now an examiner at the Royal College in his specialty. Dr. Marchand, Dr. Geneviève Marchand, is a researcher at the Robert Sauvé Research Institute in Occupational Health and Safety for 30 years. The acronym for that in Quebec is the IRSST. She graduated from Laval University in microbiology and is a member of the Canadian College of Microbiology, in which she is recognized as a specialist in environmental microbiology. At the IRSST, she is part of the research team on chemical and biological risk prevention, responsible for exposure to microorganisms in the workplace. Her work, very interestingly and very aptly, focuses on bioaerosols in the workplace, their measurements and analysis, and she has published guidelines on respiratory protection for bioaerosols. So with that, I'd like to thank you both tremendously for being here and for the tremendous amount of time you've taken in helping us prepare this presentation. I think we'll turn things over to Dr. Caissie now. Thank you.
I think Dr. Marchand is actually presenting
I'm so
first.
sorry, Dr. Marchand, thank you.
Thanks. So I'm going to share the presentation. So thank you very much for the invitation. I'm really pleased to be part of that first web meeting. I found myself a little bit far from dentistry, but I hope that what I have to present to you today will be of help for your work. So tonight I'm going to present a little bit about bioaerosol and the respiratory protection. And at the end of the presentation, I'm going to present to you a web tool that can help make the selection of a respiratory protection equipment. So before I talk directly about the respiratory protection, I think it's essential to introduce a little bit the aerosols, since the respiratory protection will be focused on only that contaminant. So the aerosol that are produced in any environment, could be sneezing, or coughing, or talking, are always made of many diameters of particles. So just because you don't really see the really small particles, it doesn't mean that they don't exist. The large particle that you see when people sneeze are never alone. They are always surrounded by a really high number of small particles that are invisible to your eyes. You have to know that the visible particle that you see are larger than 50 microns, so it's pretty large particles. Another important concept in the aerosol, when we are talking about liquid aerosol, it's that those liquid don't maintain their size in the environment. From the time that you cough, and with just a few minutes later, the large particle would shrink, evaporate, and make smaller particle that we normally call droplet nuclei. There was some study that were made that shows that in not even 1 second, particles of 10 microns get to only 1 micrometer. So it's really dynamic as the number and as the size of the particle that we can find. Another thing that it's important.
Would you be able to share your screen, please?
So that's when you sneeze, and then you see all the particles that are produced, but the one that you see, as I said, are the bigger ones, so the one that are 50 micron and larger. And that's where I was. So the other thing that's interesting on the aerosols that are liquid in the air is that the size of the particle will shrink. So as you see on those two graphs, directly at the moment of the cough, the size of the particle are closer to 10 microns, and then they dry really fast, and these in half a second, they come from 10 microns to about 1 micrometers. Because we do a lot of sampling in different type of occupational place, I thought it would be interesting to show you different graph of diameter size that we have measured in allotherapy setting, embalmers place during an autopsy and a bronchoscopy. And what I wanted to show you on those graphs is independently of the work environment where we are making our sampling, we always see a huge difference of the particle size in the environment. In the upper left corner, what you see on the screen, it's a direct reading measure that we take with an instrument that is called a UV-APS. It allows us to make the differentiation between the biological particles and the total particles. So on the graph of the embalmer and on the bronchoscopy one, what you see is what you don't see now. What you see is the fluorescent particles only. So you can see that they are from lower than 1 micron to up to about 10 microns. What I have to say though, is that with that instrument, it's not possible to measure particles larger than 15 microns. Another study that was made by a Canadian on coughing was made by Zara, who used a different equipment to measure the size of the particle. And he also found that the different diameters of the particle were really on a wide range, going from 0.1 microns up to 100 microns. Because he's using laser, then he can measure a wider range of size of particle. The other really interesting in that paper is that 99% of the particles that were measured during the cough were smaller than 10 microns, meaning that there's not a lot of particles bigger than 10 microns that are sometimes considered the droplets particles. Another study by Dr. Lindsay, in that study, he measured the RNA of influenza in order to see in what size of the particle it could find the RNA of the virus. And in that study, again, you can see that 65% of the viral RNA was found in particles smaller than 4 microns, meaning that even if the particles are really small, they can carry some viral RNA. So as a summary for the first part on aerosol, what I wanted to point out is that the aerosol that are produced is always a continuum from very, very small particles going to very large particles sometimes, that the number of the small particles is very important and cannot be neglected. And the size of the particle change over time, so there's a dynamic that's going around when there are some particles that are produced in the environment. It's false to think that the particles are emitted in the air and just stay the way they are. If it's liquid, they're gonna shrink and they're gonna evaporate, they're gonna move around in the air. So it's all that dynamic that is really complex. It's not an easy thing to study. So sometimes it's hard to understand what will be the behavior of the particle in the working environment depending on the ventilation system and on the tasks that are performed. So for the second part of the presentation, I want to be presenting for the respiratory protection. There are different types of respiratory equipment, and most of the respirators that are used for the practical will be using an air purifying systems. So most of the time they will take the air in the room and they will filter the air, so it lowered the number of particles that the people will be breathing. So on the slides here, you see the well-known N95 disposable respirator. On its size, you see the half mask respirator, where you can put a filter particle on it. That kind of mask is reusable, so you don't throw it away every time. Both of those masks have APF of 10, and I'm going to explain to you on the next slides what is APF. Another kind of mask that you can see often is the full face particle with the particle filter, and the PAPR that some people are using, which how they work, it's they have a pump on your belt and they draw the air through a filter and bring it directly in the hood, in the full face mask or in the half mask, depending on what you're using in your workplace. So what exactly is the async protection factor? Is the anticipated level of protection that will be given by respirator in your environment if you are well fit and well trained with it. So it's not anybody that can put a respirator on his face and expect to be protected. You need to know how to use it. The N95 has an async protection factor of 10. So that's meaning that when you are wearing an N95, you will lower by 10 the concentration of the contaminant that you will inhale. So wearing a respirator like an N95 doesn't bring everything to zero. You will breathe some of the particles that are in the environment. As a theoretical example, if somebody expels viral particle 10 to the 5th, with the N95, you will still be breathing, if you are a close field, near field, 10 to the 4th particles. So it's important to understand that the respirator doesn't block 100% of what's in the environment. Here I show you different type of respirator with the APF that are assigned to each of them. So you see that the full face have a protection factor of 50 compared to the N95 that only has a protection factor of 10. So with the full face, you will be lower by 50 the concentration that you are breathing compared to the concentration that is in the environment. Another thing that I often hear from people is that the N95 filter will filter 95% of the particle of 0.3 microns and more. That's not exactly how the filter are working. So if you see here on the left graph, you see how the filtration is working, or the efficiency, percentage efficiency of the filtration. And you can see that even the lower particle will sometimes be filtered, not sometime, but will be filtered at higher efficiency than the 0.3 particles. On the right side, what I'm showing you is the comparison of an N95 filter when it's as electret. So you see it's really efficient, but you see that the most penetrating particle size is a little bit more on the left, so closer to about 50 nanometers instead of 300 nanometers. The green curve is the same 95, but with that we have put in the autoclave, so we neutralize the electret. So you see that when there's no more electrode in the N95, the efficiency is going way lower. So it's important when you want to disinfect your N95 to use the proper technique so you don't provoke those kind of effect on the filtration efficiency. The other thing I wanted to talk to you today was the difference between a respirator and a chirurgical mask. A chirurgical mask is not a respirator because it doesn't protect your respiratory tract, because the particle will go on the side because it's not fit to your face. And since the air is it's really easy for the air and the particles to go inside those place where it's not fit to your face, compared to the respirator where it's really tight to your face and it will force the air to go through the filter instead of around the filter. So for the last part of the presentation, I want to present you a tool that is on the website of the RSST, and it helps people to select what kind of respirator it should be used in the work environment. So you have the first explanation and everything of the tool, and then you, the first step, will have to select what kind of environment you're in. So obviously for the dentist, we'll choose the healthcare place. And then after, you will have to choose what is the level group risk of the microorganisms you will be exposed to. As for today, the presentation will be more for COVID, so I choose the group risk 3. So that's Health Canada that decide what is the risk group of the different microorganisms. Once you've done that, then you go to the control level. That's the ventilation that you have in your environment. So in that example, I decided that you were having between 6 and 12 air change per hour. And finally, you will have to choose the generation rate. So you have very high generation, high, moderate, or low. And I'm not a dentist, but when I go to dentist, I would say that it's pretty high exposition, because you're really close to the source of the emission. It doesn't have the time to have any dilution between the emission and your nose. So I would say that high exposition is probably really close to what it is. And then at the end, you just push on the determine APF factor, and the tool will calculate what level of protection respirator you should be using. So with all the data that I've put in for the example, it would suggest APF of 25. And then finally, it will tell you with APF of 25, what are the kind of respirator that propose those kind of protection. So you have in the first one, the PAPR with the loose fit hood that has a protection factor of 25. So that's based on controlled bending. So it's not really based on the real concentration that we found in the environment, but it's a tool that can help you give you an idea of what kind of level would be proposed to protect yourself from the exposition. That's not a tool that have been made up for COVID. It's the tool that's been there for about 5 or 6 years now. So it's been around, and people have been using it in different kind of environment. So I think it's something that you can play around with it just to see in your own place what the exposition and the protection could be. So as Antoine said at the beginning, there's a little bit of controversy regarding the aerosol and the respiratory protection, the droplets and everything. And I just want to put at the end a little piece of the Judge Campbell that wrote the 200-page commission on the SAR commission. And in his statement, he's saying that the point is not really who's right or who is wrong with the airborne transmission. The point is more this, it's not the science, but the safety of the people. And that is why in the occupational health setting, we think it's better to have a little bit more protection as long as we don't know and we don't have the proof that it's only large droplets that will be stopped by the surgical mask. And we think it's better to have a real respiratory protection that will protect your lung and your respiratory tract if it needs to be. The last proposition that I could make to you if you want to be protect, it's maybe proposing to your patient to stop breathing so that way they won't be producing any aerosol in your face, and then you won't be exposed and breathing any viral particles. So thank you.
Thank you, Dr. Marchand, for that presentation. Just while we're switching over to Dr. Caissie's slide deck, I just want to say that I omitted to mention at the beginning of the presentation that, as is customary during these presentations, I wanted to announce on behalf of both speakers that they are free of any conflicts of interest related to the material that they are presenting and have no financial interests in any of the products that are mentioned there. So I just thought it would be important to mention that as we go on to Dr. Caissie's presentation. And the last point is, for those of you that are, for our auditors, you will have the opportunity, and we're going to put up an email address where you can send questions in, time allowing. The address is very simple. It's caoms.media@gmail.com. Thank you. Dr. Caissie.
Hi. Are you seeing the COVID-19, or yes, the presenters? No, so you're seeing. Okay, perfect. So thank you, Antoine, and thank you, Kevin. Hi, everyone. Thank you for joining us tonight. I'd like to thank the CAOMS and its directors for inviting me tonight. I'd like to start off by saying that I am not a microbiologist like Dr. Geneviève, and I'm not an infectious disease doctor or a specialist in medical ventilation. But these are subjects that I will be touching base on tonight. But as an OMFS, like all of you that's taken special interest in these subjects lately, I'm not here to push an agenda or suggest guidelines. I'm here because I try to find a better way to protect myself, my family, my patients, and I've been asked to share my story. So the story began last month when, like most of you, I started paying close attention to the news. And we quickly saw that healthcare workers started getting sick. Articles like these started appearing, and I asked myself, how am I different from these healthcare workers? What protection are they using? Why are they still getting sick? And we just got this after I built my deck, but we unfortunately had our first doctor from Quebec that died today, a healthy 44-year-old man. So I wanted to see if I could find a better way to protect myself. That's how the project started. So let's go back to 1987. I'm not sure I could call these the good old days. I'm sure they were. But here is an article published in La Presse in Montreal, 1987, where a provincial governing body suggests that you should start using gloves and masks to start protecting yourself against hepatitis B. As you can imagine, many docs that had been practicing without PPE probably put up a fight, stating things like, I've been doing this job like this without a mask and without gloves for 20 years, and I'm fine, right? And I believe we're at the same kind of crossroads today, not for Hep B, but for a new pathogen. So the first question, and Dr. Marchand kind of touched base on it. You know, one of the first things I wanted to know is there COVID in saliva? You know, we're working there all day and we're touching saliva. And again, she stated it well. There's still controversy on this subject as to whether COVID, it's actually found in saliva, but is it infectious? Is it dangerous to us as a healthcare worker? But just by the breathing of your patients, you're still exposed to these these aerosols. So here you see that a couple of days ago, the FDA just approved their first saliva test to test for COVID. So it's definitely present in saliva. Here's a couple of information I digged out of the Lancet that was just published in March. The medium viral load in posterior oropharyngeal saliva and other respiratory specimens at presentations was 630,000 copies per cc's. The salivary viral load was highest during the first week after the symptom onset and subsequently declined with time. And in one time, which was very surprising to me, the viral RNA was detected 25 days after symptom onset. Was it active? Is it still infectious? We do not know that yet. A little fun fact, as you've probably seen in the news, Iceland started testing profusely a big part of his population. When this test was done, they tested 1/10. They just wanted to pass everybody, symptomatic or not, for the coronavirus, and they found that half of those who were positive had disease without realizing it. We'll get back to that information later. So here's a study that was done by Dr. Marchand in our hospital at Sacre Cœur Hospital in Montreal, where they studied the dispersion of bioaerosols in a negative pressure room while doing bronchoscopies. And if ever I'm saying anything wrong, Geneviève, you can definitely cut in here. So this is, here what we're seeing is a computer model of what they found with using UVAPS, so ultraviolet aerodynamic particle sizers to test for aerosols. So here you have a patient lying on a table and you have two healthcare workers. And the tube here that you see on the ceiling in blue and black is the negative pressure apparatus. So I'll start the simulation. And here after, right away, you see a high concentration of aerosols and it quickly disperses across the room. And you see here after 2 minutes, there's still quite a bit of aerosols, even with a negative pressure room. And this also, what we need to note here, these were bioaerosols. So they're possibly infected aerosol particles that we're seeing here. And this is after 2 minutes. There's still quite a bit, bouncing around the room. I've also found this that was done in Japan. You've probably seen these videos go around. They've been published many times, where you have two individuals that are just talking. And they're using the same type of equipment, and you right away see a large accumulation of aerosols that are formed just by talking. And here we see the same type of simulation with these cameras where somebody sneezes in the room, and this is a room with regular industrial ventilation. And these are, again, bioaerosols, so possibly infected aerosols. So you see after 6 minutes here, everything is still there, that's suspended in air, 15 minutes, not much has changed. And after 20 minutes, most of it is still present in the room. So without proper ventilation, these aerosols can stay suspended in air for a long time. Now, I know there is controversy on the infectiousness of COVID on particles, but there's definitely reason to be worried. So now let's look at the behavior. Let's look at a few scenarios here. Let's look at the behavior of what happened on the Princess Diamond cruise ship. We can look at this as a closed environment, like a country, if you want. There were 3,700 people on this ship. 634 people tested positive. And out of these 634 cases, 18% were completely asymptomatic. So basically, firstly, we know that biological aerosols remain in suspension for a great period of time. There's still debate on this subject as if you can get infected, but we have to keep that in mind, that there's a lot of bioaerosols that are staying up in the air. Secondly, there's a high proportion of COVID positive patients that are asymptomatic, as we saw here. And there's many examples of this where in Iceland, there were up to 50% of the patients that were positive that were asymptomatic. And there's been data showing that these asymptomatic patients can infect other patients. To the same degree or not, that is still in debate. And thirdly, there can be a long incubation period where patients are initially asymptomatic, but they can still transmit the disease. Hence, we have to ask ourselves if, when we see patients in our offices, if we shouldn't not consider treating most of our patients as if they were COVID positive patients. Then that's the way I started looking at it in my office setting. And so let me go to the next slide here. So now, what are the aerosol generating medical procedure with demonstrated risk of transmission? I took this off of the Commissions for the Prevention of Nosocomial Infections on the Quebec website and provincial website. So at the bottom here, all nasal or oral pharyngeal surgical procedures in confirmed COVID-19 or in asymptomatic patients when sustained community transmission is present. That is pretty much where we are now. So what are the issues in the OMFS setting? What did I look at in my personal office with this data that I've been looking at for a while? So first of all, we produce a high concentration of aerosols and droplets when we work in the oral cavity. There is COVID present in the saliva. The patient is breathing. We're using high-speed surgical pieces that are pushing that breath out towards our face. We have a high turnover of patients. We see patients in most of your clinics. We're seeing 20, 30 patients a day. We're underprotected with our current PPE in this situation, in the COVID situation. Most of us are. We have an augmented risk of contamination of the medical team and cross-contamination of patients because of what we do. We work in the oral cavity like anesthesiologists are intubating patients. This is not, it's not your typical treatment. And most clinics, I don't want to see all, but most clinics have airflow that is probably substandard if we compare it to our medical counterparts. We've discussed this today a lot, where if we look at the provincial guidelines for a plastic surgeon that wants to open up shop here in Quebec, the rules are completely different. They have to have negative pressure rooms here and positive pressure rooms elsewhere in the room, and everything's very, very reglementary. So these are the issues that I wanted to look at in my personal office. So let's go to let's address these issues. This is my actual setting. This photo was taken a few days ago from my office. So to address these, the production of a high concentration of aerosols and droplets. So one of the things that's been pushed a lot by the IRSST and the nurses at our hospital, they keep talking about capturing the particles at the source. Before they go all over your room, let's try to get them, into a filtration system. So that's the first thing we did. This arm here is a telescopic arm that's hooked up to a ventilation system. So the air that comes out of that comes into that cone that we hope capture everything that's coming out of that patient's mouth, goes through a HEPA filter, and that air is pushed out. And this machine is so powerful that it actually acts as my negative pressure machine. So I have more air pulled out of the room than air coming in, and I have a differential from the rest of my clinic. So I control where that dirty air is going at all times. I don't want it to go to the rest of my clinic. I want it to go outside after it's been filtered. Second thing we wanted to address, we said we were worried, in my clinic, we were worried about contamination of the team. So this is a completely separate system. I guess you could classify this in the PAPR apparatus. So we use positive pressure. What I didn't like about the regular PAPRs is that we used filtration, which means, as Dr. Marchand showed you, we have a belt around, you have a belt with a filter with a pump that takes, you know, possibly dirty air, pushes it through a filter, and it pushes it into your helmet. And she showed it very well, and she said that filtration, we can never get 100%. So if you take, let's say there's 200,000 particles, you're filtrating with a ULPA filter at 99.999, which is the best filters on the market, you're still leaving 200 particles that are going into your mask that are possibly COVID positive that could infect you. So we wanted to stay away from filtration. So what we're doing, we're taking air from outside, like outside clean air from out, like, well, City of Montreal air. We think it's clean. That's passed through a ventilation system that has a HEPA filter, and it's pushing positive air pressure in our PAPR here. So we're sure that we're not doing any filtration. So both of our systems, instead of relying on filtration, is moving air around. We capture particles at the source, we push it through a ventilation system, and we push it outside. And then we take air from outside, far away from where that exhaust pipe is, and we drag it into our positive pressure environment. And what that causes, that positive pressure pushes against the lining of our CCM hood here. And if inadvertently there was a little rip or anything, it's, you know, the pressure can't let anything in. And you don't have to wear a mask under it, and it protects your skin, your ears, any exposed skin that you could have, nothing can get to you. So with this kind of system, and again, this is just our personal beliefs, this is not what's going to happen across the province, but with this, we actually have laser particle measurers where we can see the particle numbers going down, and we've calculated that in a room we could change the air or bring the particles down back to base level within about 6 to 7 minutes with this thing. So we can, you know, we were talking about one of our problems was low turnover of operatories. You know, I keep having that image of these particles that are flying around the room after somebody sneezes. I can imagine the same thing, or Dr. Marchand's simulation, we see these particles after a bronchoscopy just flying around the room and they're staying stagnant. So what we don't want is to have a contaminated room for the next patient to walk into. So I will now walk you through how this project happened. It kind of happened accidentally. I didn't plan on this. I do not plan to commercialize this, and I do not sell these hoods. CCM will sell them at cost, and we'll discuss that later. We happen to work with a company called Orkin. This is where we got our systems. I'm sure there's a bunch of these companies across Canada, but these guys are world experts. They've actually they're the ones that build the ventilation system in the Wuhan hospital that was built within a week. They have a factory here where they build these ventilation systems, and the rest, they have also offices in Wuhan and in Asia. So this is the telescopic arm that's hooked up to a box, and that's where the ventilation system is hooked up to. So this is the ventilation box here, which is mobile. And we need two of these same, in our room, we're using two of these boxes. One is pulling dirty air out, filtering it and pushing it outside, causing negative pressure and capturing particles at the source. And the second machine, the same type of machine, does the opposite. It takes clean air from outside, filters it, pushes it into our hood. So this was, so the way it happened, I have a severely asthmatic 2-year-old child that we adopted from China last year. I have 2 kids. I have a little daughter that's 6 years old, and we have Thomas, our son. And every time he gets the common cold, we're at the children's hospital with a severe bronchospasm, just with a common cold. And when this hit, that's the first thing that I thought of, is how do I keep that bug away from my home, from my family? My child I think he would be in real danger if we ever brought this home. So I just wanted to find a way to completely protect my head, my respiratory, my lungs, and the rest, everything, my hair, and protect everything. So I designed a first hood in my garage. This is surgical paper that we use to wrap cassettes. This is level 4 tissue that is an impermeable to most biological hazards. I'm not going to show you the first hood because it looks ridiculous. My wife knew somebody at CCM, and I called up on a Monday morning. I called up the director of the factory, and he right away said, "Come over." And within a couple of hours, I was at the CCM. He brought in these people here who are designers. This factory here, this CCM factory, they only do NHL equipment for the pros. So they do this. They build Sidney Crosby, Ovechkin, Carey Price's stuff. So these guys are very set on design, and a very, very impressive team. We worked the entire day, and by the end of the day, we had a hood that was looking pretty good. This was our first model here. So basically we use acetate at the beginning, surgical field, and it goes down to your mid-thorax. At the beginning, we didn't even want to go positive pressure, and we actually tested these hoods. They outperformed the N95 mask when you're wearing a surgical gown on top of it. But after half an hour, we used Capno, and our CO2 levels kept creeping up after half an hour. But it's definitely a good option if you need to get into a hot spot quickly. You don't have to don all your equipment. This can be put on in a few seconds. So this was done the first day. They drew the first plans, and within I'd say 4 hours, they had a laser machine that was cutting a surgical paper to mass produce this. It's pretty impressive what they have there for equipment, and the efficacy of how they work. It's very impressive. So that first day, we went to the lab hospital, tested it in the lab where they test the quantitative fit test for N95s, and we got pretty good results. We were very impressed. So we went back and we decided to push the envelope, and that's when we had the idea of using positive pressure. And we wanted to stay away from the PAPR designs, like I talked about, to get clean air and stay away. We wanted to try to find a way to see patients without any filtration whatsoever. That was at the end of the second day here. We'd started producing to start testing a bunch of hoods. So when we went into the second day, we tested a whole bunch of hoods to make sure that we didn't have any flaws in production. And then the third day, we realized that there was no more level 4 medical paper available. Somehow somebody bought it all out, and within a couple of days, we had thousands of yards available on one day, and the next day was gone. So we had to find another way, because our idea was to try to build a protective piece of equipment where we didn't have to depend on any other country. We wanted materials that could be found here in Quebec. So I literally went to Home Depot, picked up some Tyvek. Tyvek is a medical wrap for our houses. And we built the first prototype with Tyvek, literally from Home Depot. We went back to the lab, and again, we outperformed the N95. And when we used positive pressure, we really outperformed the N95. And that's when I was suggested to reach out to Dr. Marchand at the provincial IRSST lab for further testing, which is what we did. So they have a really crazy CSI looking kind of lab. It's very impressive in there. Here, I just wanted to give you an example of what kind of equipment they're working with. I think, Dr. Marchand, that you're the only lab in Canada that's doing this kind of testing with masks. Is that correct?
Right now, yes, because we built that for the COVID, to respond for the COVID problem.
Okay. Amazing. So this is one of the PhDs here. He's got a postdoc in biotissues or something. Very smart guy, too smart for me to talk to. So he's pushing some red liquid in this line, and they can simulate speeds of coughing and talking and sneezing, and that red liquid goes through the mask, and they have sensors that goes on the side of the mask and in front of the mask, and they can measure what actually gets through a level 1, level 2, level 3, and 95 mask. This is how they're testing it. One of the ways they're testing it. We can actually hear Dr. Marchand explaining to me what's going on here. Pretty impressive stuff. I was very impressed. And so our first day, well, actually, the first day I showed up at the lab, Dr. Marchand told me to leave because my CO2 levels were getting too far up. So she told me to come back with positive pressure. So we came back the second day at the RST, and these are our results. So we measured up to a protection factor of 100 versus a protection factor of 10 for the N95 masks. And we believe, I will let her talk for herself, but we believe that we can go get the 1,000 rating. We just didn't have the equipment there to go measure that. So this was a happy day. So this is our setup again. You see the suction. We try to put it as close to the patient as possible. For those who know him, this is Dr. Jacques Goulet, who's being my patient for the photo op. And you see the tube coming out from the back of the mask here. You see that tube coming in the back here. So here again, this is the Centre de contrôle des infections nosocomiales du Québec, the same agency as I was talking to you about. And these are the recommendations for AGMP with demonstrated risk of transmission. So additional airborne and contact protection, including ocular protection, limit procedures if possible, limit the amount of personnel in the room, use of adequate PPE, and respect wait times between cases to allow 99.9% of air elimination before re-entering the room without PPE. So this definitely is something we need to look at, in my view. How do we measure that? When does that happen? Does that take 3 hours? Does that take half an hour? When do we do it? Because I certainly wasn't doing this last month in my office. This is a study that just came out last month in the JAMA, which are the safety recommendations for head and neck surgeons. So here are aerosol generating interventional procedures. The Canadian associations of ENT and craniofacial surgeons came out with the same type of recommendations 2 days ago. So here for high risk to clinicians, so patients with either active COVID, patient with influenza-like symptoms, or patients under evaluation for COVID, they're recommending a PAPR or a single-use N95 mask and the rest of the stuff, as you can imagine. And for low-risk clinicians, so they're suggesting, if possible, test the patient within 48 hours of the procedure, and patients who are asymptomatic and untested and negative in 48 hours, they're still suggesting at the very minimum an N95 mask. And the Canadians are right behind there for the Canadian ENT Association. Before we wrap this up and we open up for questions, we've been also working with a team from Stanford, and I believe Dr. Stanley Liu is watching this now. He's a maxillofacial ENT from Stanford University, and him and a bunch of very smart people from Palo Alto started developing this app. So it's basically, you might have seen there's a few companies doing this, but not with this type of precision. So it's an iPhone app that you download on your phone. It takes a 3D scan of your face. This is a photo I took this morning, and it actually molds a mask to your skin, and it adapts it perfectly. So you get a really nice tight fit. And this is also an option that came out yesterday, where we can print a silicone seal that you can adapt to this to really get a snugger fit. But I found that with just the plastic that we've been printing, it works really, really well. So this is one of the types of masks. So we've been testing with ULPA filters, HEPA filters, and different types of membranes. And we're actually going to the lab to test these. So if these work, and they should work, we really think they will, this would mean that anybody could basically take an iPhone app, take a picture of their face, and print a fully adapted N95 mask. And all they have to do is just change that little piece of membrane. And the beautiful thing here is that we're crossing our fingers, and we'll be in the lab on Monday, Dr. Marchand, testing this. We're using some membranes that are readily available here that people aren't using yet. We really think that they're going to give us good results. Before last slide, I've been contacted by a team of researchers from a local hospital here, and they want to adapt this hood that we've created so patients would start wearing it. So we were talking about controlling the particles at the source. This is one way to do it. So we've actually connected the hood to a CPAP machine. This is a ResMed CPAP machine. And they're just going to add an exhaust here so they can control the outflow of the COVID particles, and it would go to a filter and then pump outside. So they really want to try to stay away from intubating the patients. As you know, only 20% of patients are surviving intubation. So they're trying anything to push the intubation as far as possible. And they think by having positive pressure in a hood like this with high oxygen, that they could push that off and use this. So hopefully they'll start the clinical study this week. And so now that we're out of the lab at the RSST, now the project is at the Ministry of Health. It is not approved yet. Canada Health has it on its desk, and we're hoping to get full approval at one point. To conclude, to get back to our first slide, I understand that our governing bodies have to be pragmatic in their recommendations of the appropriate type of PPE to be used, and that these recommendations have to take into account the availability of materials, the associated cost, the distribution, the perception to the public, just like they had to back in 1987 when they suggested the use of masks and gloves. I also believe and understand that the type of PPE used is affected not only by the recommendations of those governing bodies, but is also a very personal choice. I explained to you why I wanted to try to have extra protection, and I know this is not for anybody. And I have a couple of friends that work in the ICU, and one of them is called Mark Beliveau, and Mark is married, doesn't have kids, and he's willingly wanting to get it so he can get back to work as quickly as possible. So I think protective equipment becomes personal at one point. But I can't see that we're going to go back to the same type of practices as far as our air quality and PPE goes in the post-COVID area. There's going to be mounting pressure from many sides. We're going to be pressured by our staff that will be wanting extra protection, by our patients that will be more educated in the presence of long-standing aerosols in surgery rooms. We might even be pressured by immunocompromised family members that want us to take special care to not bring any bugs home. I thank you for your time.
Great. Thank you, Dr. Caissie, for your presentation. I would just point out one additional factor, in all fairness to provincial governing authorities who have a very particular challenge in these difficult times. I think the one other factor and variable that I would mention would be to mitigate the risk at the lowest possible level for the population at large and for us as practitioners. René, if I can get you to stop screen sharing, please. Great. So
I was gonna go on my Facebook there. Thank you.
No problem. I love the printable mask. I think it's got a huge potential, and for very obvious reasons, they are in short supply. And so if this is something that can be produced and readily available and approved by health organizations, I can't imagine it being something that would be a bad idea. Now, statement, and we've been practicing oral surgery for many, many years. I have personally, and there are a variety of circumstances and medical conditions taking care of very sick people. And many of us, have been wearing basically surgical masks and glasses, and we haven't gotten sick yet. So I'm going to throw this out at you. I would say, your system might be perceived as being overkill. How can you possibly expect, or how can you, maybe you do, but do you expect that dentists or oral surgeons out there are going to adopt this system and implement them in their offices tomorrow?
So first of all, this is a type of PAPR, and it's been recommended at large for our ENT colleagues at the provincial level, at the national level, and same thing in the US. So this is a PAPR, so it's not overkill for ENT surgeons. So overkills, it depends. Like if we're talking, are we talking overkill in terms of costs? These are going to retail, CCM says they're going to be selling these at cost. For they think between $15 and $20, and they should be reusable. We're going to be doing tests. So in terms of cost, I don't think they're overkill. Overkill in terms of donning on the equipment and taking it off. We've done some tests to make sure we didn't contaminate ourselves when we were taking it off. And it takes about 12 seconds to put on and the same amount of time to take off. And it's extremely comfortable. If for most of you have probably tried N95 masks and goggles and a visor and a surgical hat, it gets really hot in there. In a PAPR or in a system like this one, you're very comfortable. You've got flowing air, there's no fog, you can talk freely, you have no mask on. So it's not overkill in terms of discomfort. Overkill in terms of protection, maybe. However, when I think of all the healthcare workers that have been infected, those that have died, one has died today, and especially when I think of my 2-year-old son that becomes severely asthmatic when he gets a cold. When I think of him, to me, it's not overkill. I personally want to overkill my approach to security, to practicing. It all comes down to using what you have at disposal. Why wouldn't you use the top type of protection that you can get your hands on? If you don't have a PAPR, don't use a PAPR. If you don't have an N95, don't use it. But let's say you have all three options in front of you, sitting in front of you in your office. Why wouldn't you use the safest method to protect yourself? Like Dr. Marchand quoted, I'm sorry, I forget the name of the quote, but at this point in time, we should maybe aim for security, and because there's a lot of debate out there about infectious rate, aerosols. Can we get infected by doing oral surgery? So why not use the maximum available protection that's out there? I'm not saying it's for everybody, but it surely is available, or we hope it'll be approved, and it could be used by some people for sure.
Well, the question relates to the number one. I mean, I understand that the PAPR itself, the mask itself, for the device is only going to be sold at $15 to $20, but certainly there's a cost to the air inflow of that device. I realize it's potentially a fixed cost, because it can supply, from what you've explained to me, numerous masks at the same time. The other question is this something that's adaptable to the dental clinic environment? In other words, that the arm that subtracts the air at the source or vacuums the air at the source, is that something that fits into the average oral surgery operatory?
Yeah, as you saw the box, it looks like a small refrigerator. Again, there's probably more models out there, but the ones we use are very compact. The arm we just literally rolled it in there, connected it to this air purifying system, and we had a plastic, what is it called? A plastic to replace a window. We had an exhaust placed in there. It took the guy 15 minutes. It was really not a hard fix. So we're now pulling at the source, and we're having a negative pressure environment. If I had a new clinic, I probably wouldn't build it this way, but as an add-on, it was extremely easy, and it's not that expensive to add on.
Why do you say you wouldn't build it that way as a new clinic? Can you elaborate on that comment?
I would have centralized negative pressure rooms like we have at the hospital. The arm, I would probably have it fixed over the patient to have it down a bit like a dental lamp, so it would pull up and away, so we wouldn't have to have that little fridge. But in terms of cost, it's not that costly. It wasn't that costly to us. I think the machines costs, little fridge, the air compressor cost $2,000. The arm cost $1,500, I think, $1,500. So they're fixed costs, and now we have a negative pressure room where I can.
Yeah. Can we quickly segue into the question of, I think most of the listeners are probably familiar with the concepts of positive pressure ventilation versus negative pressure ventilation. We know that most operating rooms historically, and today actually, function with positive pressure ventilation for the sake of mitigating or minimizing the risk of infections in patients. Dr. Caissie or Dr. Marchand, would you care to speculate on the notion of increased risk of infection in procedures with negative pressure ventilation? Is that something, that guy over there? Rene, I guess.
So, yeah. I understand the question, and I don't have any data on that. I didn't look into that. I know for a fact, I was talking to the CEO of Orkin yesterday, and he told me that Quebec hospitals have ordered 650 of these units to start placing a lot of rooms in negative pressure in operatory settings. And if we look at what they did in China and Wuhan, that hospital they built in a week, all of their rooms there are built in negative pressure. Again, they want to take dirty air and shoot it outside, and not having they don't want to recirculate it in the environment.
Right. So from what I understand, just because I don't want the perception to be that I've just shot you in the foot on this question, the point is that negative pressure ORs are usually combined with an inflow of positive pressure in the clean area, so that what's being sucked into the operatory is a clean area. So I think it's a question of ventilation mechanics and getting engineers involved with that. I think, let me just say that I think the amount of energy and the industriousness that you've put into developing this is really quite admirable. And I think the fact that you've been able to bring together industry to respond so quickly to a medical need is really quite admirable and not unexpected of you, for those that know you. I just want to throw, so it seems that there's been quite a positive response to this at the institutional level from what you've just described.
There has. I've gotten calls from well over 25 chiefs of services, from ENT, anesthesiology, ICUs, to see when they could get this technology. And they, especially the healthcare workers that are high risk, they see a benefit of using a PAPR type of equipment. They don't want to be exposed directly. You know, we're thinking about intubation. We're thinking about bronchoscopies. You know, it's not unlike what we do. They're afraid to get their face right close to the patient's face. We do that. They're pushing a tube, 2 inches from where we're going. So there's been great enthusiasm, and what we keep telling them is that it still needs to get approved. This technology needs to get approved by Health Canada, but the concept has been proven. I did not invent this concept.
Right. So one interesting point that I'd like to emphasize is the notion that took me a while to understand was the appreciation for moving of air versus filtration. So ventilation versus filtration. So what's interesting is that we understand that most filtration mechanisms, even the most sophisticated ones, may leave some residual particles in the air. And so in many centers, what they've been moving towards, and what this concept moves towards, is actually moving air into the mask in a positive way, so that filtration is actually not really necessary at the viral level, but mostly at the intake level, to filter the air from the outside that the clinician is receiving in their mask. And the second is, there's probably a lesser demand of local air filtration because you're using something called captation at source, that's moving the viral particles in the aerosol immediately out of the room. Since we're on the subject of ventilation and filtration, either Dr. Marchand or Dr. Caissie, in response to this, what's going on, at least in our vicinity, there's been a lot of talk about HEPA filters in the form of air purifiers that theoretically sit on in a dental operatory or an oral surgical room, and they're purported to purify the air, and we would think intuitively that there might be a benefit to using them. Can you comment on their efficacy? Either one of you.
I'm not an engineer in ventilation, so I'm a microbiologist, so it's hard to answer those questions. But one thing that came to mind, if it's those machines, if they move the air around, then you can just move the particles around depending on the disturbance that they will create. But more you remove the particles from the air, better it's for you too.
Right.
So from what I've heard in the past 2 weeks of spending time with these engineers is the first thing you want to do from a room is take that air, pass it through a HEPA or a ULPA filter and shoot it outside for 2 reasons. The filtration, as we've discussed, is never at 100%. So if you're not evacuating the air outside and you're recirculating, you're still re-pushing some viral load back into your environment. Secondly, that air that would be created by re-pushing air into your office would create turbulence. And the particles that have settled on surgical fields, the floor, on your equipment, could be pushed back up. So what I've been told was you gather at the source, you filtrate because you can't throw dirty air out, and you filtrate it and push it up.
Okay. So the important concept there is I don't pretend to either be an authority on the subject, but obviously I think the take-home message here is if you're going to install a HEPA filter, that's great, but try to make sure that it's vented to the outside world in an appropriate manner that respects construction norms, and make sure that it doesn't exacerbate turbulence in the air in your operatories. We'll leave that subject. Dr. Marchand, I enjoyed your presentation on masks, and you know, I have a wheelbarrow of N95 masks. Actually, that's not true. I wish I did, but I don't. Can you comment on, based on what you just said, I have to ask you the question, is an N95 mask, in your mind, an effective infection control instrument or armamentarium?
Like I said, the N95 will help. It has a protection factor of 10, but it's not going to bring everything to 0. So it will depend on what's the level of contaminant you are exposed to. I think that source captation can help a lot, and in occupational health is something that we will often put forward. And then if you have a good source captation, then your N95 might be enough to lower to a level that is acceptable. But you have to know that the N95 is the lowest efficient respiratory protector.
I mean, because you're not even considering that a surgical mask, a conventional surgical mask offers minimal protection.
A surgical mask, anyhow, in Canada, it's not a respirator. It's not considered that. In occupational health, it's not considered a respirator.
Okay.
Can you comment on the importance of the fit testing of the N95 respirator?
If the N95 is not tied to your face, it's like wearing a surgical mask. So the hair is, we say it's really lazy. It's going to go where it's easy. So if you have leak around your face, the particle will go there, will follow the flow of air there. So if you're not fit tight, it's not worth it to bother wearing a N95 or any other respirator. If you have half mask, it's the same thing.
Okay. I think at this point, what I'd like to do is, and something that we've discussed in preparation for this, is talking about risk stratification. In other words, in my conversations with infectious disease specialists, when you're performing surgery or manipulating the airway, if you're performing surgery and you're cutting into respiratory epithelium, where COVID viruses reside and replicated in an ill patient, or if you're, for example, doing a bronchoscopy on a patient as an anesthetist, there's going to be a certain viral load, a known viral load in a COVID positive patient. My conundrum, if you will, and my dilemma in listening to what you just said is the fact that our healthcare system at large really seems to be relying on N95 masks, and they are as we said, they are in shortage, and people want more of them. ultimately they are the workhorse of respiratory protection in the medical healthcare system. Would you agree with that?
Yeah, that's what they use mostly, because I think the reusable mask, you need to make the disinfection of it, and I think that's a thing that they don't want to do in the medical environment.
Meaning, so but N95 masks, there have several techniques of sterilizing these masks that have been described. Are they valid in your estimation?
As I showed in the presentation, I show you one mask that went through the autoclave. It's not all masks. They won't, depending on the company, they don't respond all the way the same way, but the mask N95 that are working with the electret, if you neutralize those, then the filtration efficiency gets really, really low.
Okay. So let's flip this back to a clinical scenario. Dr. Caissie and Dr. Marchand, for your input would be appreciated. It's July, and very much hoping that we're on the other side of this social distancing, and that the curve isn't flattened, and a lot of people are much, much healthier. And it's July, and our offices are open. And Dr. Marchand, let's pretend for a second that you're an oral surgeon, and that you, just for fun, and you had to remove wisdom teeth on a young patient, 21-year-old patient who's healthy, presents no signs, and is COVID negative by all the definitions that we would currently accept, and has been COVID tested and found to be negative. False negatives notwithstanding, because I know that's an issue. What would be your recommendation for personal protective equipment in that context?
I think the minimum that I would be wearing is an N95, because now we are talking about COVID, but is there any other pathogen that you could be exposed to that you would like to protect yourself? I'm thinking about tuberculosis, but there's all kind of respiratory pathogen that can be present in your patient and you don't necessarily know it. So right. From my point, I would put N95 the lowest.
Okay. So in your presentation earlier, you mentioned there was mention of the influenza virus. And so in the context of what you just said to me, is an N95 mask adequate is an N95 mask an adequate preventive PPE to wear to prevent you from catching an influenza virus?
It will depend on the other engineer control that you have in your office. If you have the source captation and you grab all the particles before they are getting to your nose, then I think the N95 is okay. If you have a really low level of ventilation and you are performing really high aerosols procedure, then maybe the N95 is not enough, as I was showing with the tool, and you have to go with a higher factor of protection.
Okay, so I'm going to save us another question. I'm going to address the issue then of dealing with the way we currently classify procedures to quantify risk in oral surgery and dentistry is aerosol generating high-risk procedures versus non-aerosol generating what we call low-risk procedures. So I'm to understand that your recommendation would be that in the current COVID crisis, under the current circumstances, with the risks of a community infection at a fairly high rate and asymptomatic patients, that perhaps one might consider the use of an N95 mask even in a low-risk non-aerosol generating procedure. I can tell you based on that statement that if I were to follow your recommendations and I were doing jaw surgery or an extensive trauma surgery on a patient in an operating room, that like my ENT colleagues, I probably would want to wear a PAPR or a powered air purifying respirator rather than just an N95 mask. You would agree with those conclusions?
Yeah, for sure.
Okay. Dr. Marchand, there's obviously, and this is maybe where some controversy may arise. I understand that there's a huge amount of controversy and perhaps conflicting opinion on the notion of airborne transmission of the COVID virus. And I guess I'll just read my question to you. But can you comment on what evidence might be available to support the notion of droplet transmission versus the other phenomenon of airborne transmission, which is obviously a significant concern? Can you comment on that?
I would start to say that I don't think it's one or the other. I think in the presentation I made, I show that when you have emission, you have large and small particles. So you have large droplets and small droplets. From my opinion, I think that we should more be talking about close transmission and further away transmission. But in the close transmission, I don't believe that it's only the large particles that are the risk, because there's so many small particles in the emission that they probably do contribute to the problem of the transmission and the contamination. And that's why I think that it is important to have a respirator and not only a surgical mask when there's emission and when you're working close to somebody that's sick.
Okay, so I just want to make sure that I fully understood what you said, because it's very important. You said when you're working close to somebody that's sick.
Yeah.
So
then I will say, since you don't always know if someone is sick or if it's asymptomatic, if from my point of view, I wouldn't just look in the eye and decide if I wear a respirator or not. But
okay,
if we are talking about viral emission and everything, if you want to have viral particles in the air, you have to have someone that is sick.
Okay. So the other way to put this, as a good friend of mine stated it to me very recently, was if on your shelf you have an N95 mask and you have a PAPR, and you have to do a surgery, you're going to take the PAPR, right?
Always.
And I'm sure there's a lot of ENT surgeons and maxillofacial surgeons that probably agree with you out there. I would very much like to bring this back now to, if we can, to the discussion of clinical relevance and the discussion of clinical reality in oral surgery and dental practices. I think that it would behoove us to leave our listeners with some sense of advice, Dr. Caissie, if you will, on, let's just pretend that I'm an oral surgeon that works in a clinical environment where negative pressure ventilation is not possible. I'm maybe shopping for a HEPA filter. I'm not even sure if I can evacuate the HEPA filter to the outside world. I'm worried because maybe I work in another province. But I do work in Quebec. But that being said, if I maybe work in a jurisdiction where the governing body is going to decide to lift the ban on clinical practice overnight, and I'm going to be confronted with, obviously I'm going to go through all the preparation that I can in terms of using strategies of appointment staggering, maybe doing shift work with our employees to minimize cross exposure. I'm going to redesign my waiting room to allow for distancing of chairs from one another, perhaps go to an entirely paperless workflow to not have patients have to touch anything in the office, not have anybody wait in the waiting room, using a text messaging system to have them come directly into the operatory. And obviously there's a whole education of our team's perspective of assistants and secretaries and sterilization teams to basically bring them up to speed on what needs to be done to protect us. But let's bring it back to Dr. Smith, who works in an office. What advice would you have for him? What would you have them take away from this and say, what do you need to do tomorrow? What do I need to do tomorrow?
So I think the first thing that I would look at would definitely be go back to your offices and checking ventilation. Like Dr. Marchand said, I think if you can capture the emission at the source, you can probably downgrade your level of protection, your PPE equipment. I personally think that is not a hard thing to do. Even if you think I was called by the Children's Hospital today and they say, we're in the middle of the hospital, how would we do this? And if you look in any room in any hospital or clinic, you have an exhaust pipe and an entry pipe. You can exhaust, and you can have a portable machine with a portable arm. So I think then captation at the source is not an issue if you want to do that. If you believe in that, I think anybody listening today can probably do that. The second thing would be, to go back and evaluate the risk of the different procedures that you do in a COVID situation, and you have to decide what you think is dangerous and not. With your new awareness of aerosols and PPE, you can make a better informed consent on what devices you should get in your office.
But is it realistic for me to consider doing, so maybe based on what you've said, I'm going to start to think about practicing dentistry wearing an N95 mask, at least for the foreseeable future, because based on the conversation we had and the information that we received, that might be a choice to make if there are N95 masks available. If there are no N95 masks available and I can get my hands on a CCM PAPR donning mask, is that okay? I mean, can I put one of those on me and one of those on my assistant and presume that we're going to be safe during a procedure? And assuming that we get our ventilation at the back of the hood, as you've described.
If it's done properly and it's taken off properly, it should protect you, we think, to a higher level than an N95 mask.
And so, but if you're in a room where there's no adequate ventilation, I guess it then becomes a question of waiting a certain number of hours to allow for particles to settle and to leave that room alone for probably an extended period of time, like 3 hours before you can go back in, if you didn't have any kind of air filtration.
Yeah.
Okay.
Again, I'm not a filtration specialist.
Okay. I'm just going to take a question online since somebody's taken the time. Stuart, can you please put up the email address in the slide to inform our members?
I actually have one from Robert Paquin.
Okay.
And I think this could be addressed to Dr. Marchand. He's asking if there's anything about lowering the viral load with, disinfectant mouthwash. So basically, we're kind of saying that the risk is coming from the saliva and not the patient breathing while we're operating in him. So what's your point of view on that, Dr. Marchand?
I haven't read any study on that and how it lowers really, does it completely lower the viral load? I think it will lower what you have in your saliva, but everything that is in your respiratory tract will still be coming out. And I don't practice dentistry, but if people are coughing close to you, then they will bring viral particles that are coming from the respiratory tract as well as the thing in their saliva.
There has been reports out there that hydrogen peroxide mouth rinses are effective, and I believe the concentration was either 1%, 3%. 1%. Colgate makes a product that you can buy over the counter. Amisan is the powder that's mixed up with water. And with water swishing it around, it releases hydrogen peroxide. And I think Amisan is about a 3% solution. Again, I think these are somewhat anecdotal. I don't know if there have been any true scientific studies on it. But having said that, when this came out for my emergency patients that I was seeing, here's some 1.5% hydrogen peroxide rinse with it. It was either that or the Listerine that we were using before.
The dilemma there, and the dilemma that remains, and that was brought up by this question, is the fact that we're not necessarily concerned about the saliva, but clearly our patients need to breathe and they'll occasionally cough, and there's tremendous amounts of fluid in their mouth while we're working on them. So coughing and of course breathing is inevitable. You can quote me on that. So aerosols will emerge and droplets will emerge during that action of breathing. So it's a combination of aerosol from the dental procedure itself and the aerosol that's generated by the person breathing or coughing, which is a concern. There was one more question, Dr. Marchand, if you don't mind. One of our participants asked, can you comment on the difference between N95 and P100 filter/masks for COVID protection?
The N95 is the basic respirator, so it filters about 95% of the particles. The P100, you can have two ways to have P100. One is with a reusable mask where you put the cartridge, so it will filter a higher level, and you have the P100 that is disposable as well. But from my point of view, the P100 that is disposable is really not easy to breathe through. So I would, if someone wants to go with the P100, I would go with the half mask or the full face reusable, because it's a lot easier to breathe through. But it has the same assigned protection factor than the N95. Both are at 10 of protection if you are wearing the half.
Right. Okay. So I think, Dr. Caissie, do you have any closing remarks that you'd like to share with us?
So basically, personally, I agree with Dr. Marchand. I'm gonna, if I can get my hands on N95, I'll be using N95s to do the low risk examinations and anything that doesn't generate aerosols. But as soon as I'm sitting down and I'm touching the patient, I'm gonna use what I have, like the best protection that I have, until we're 100% sure that there's no conflicting data anymore. I'm going to use the maximum protection for myself, my team, and my family and my patients. So you asked the question, if there's an N95 mask, a surgical mask N95 and a PAPR in my office, what I'm going to use to do any types of surgery, I'm going to overprotect myself and overkill it, like you.
Okay.
You asked.
And what if you just have to remove sutures on somebody? That's COVID, presumed to be COVID negative.
And again, I have I have these hoods in my clinic, and I have the positive pressure system set up. And it takes a few seconds to put on. I'm going to use it. The patient's breathing, and there are false negatives that are going around there. I want to protect myself, and I'm going to use it. And I know this is not for everybody. I know I'm over the top protective of my environment. So again, I didn't want to push an agenda tonight, and I hope it didn't come across that way. It was just to present an idea. And I will keep overprotect myself until everything is gone and we're sure there's no risk of infection anymore.
There's our esteemed Dr. Matthew Lennis has just asked the question, if we can just take 2 seconds, and I do appreciate your comments, Rene. How do you remove your CCM device without contaminating yourself? Mathieu, so, I'm assuming that you're referring to the headpiece and not another piece of equipment. Sorry.
Yeah, good question, Mathieu. So we actually, this is one of the things we're working at the hospital. There's a team there that does these types of procedures, and we practice. So basically, the hood is taken off from the top. By grabbing it, we bend over, and it slides off, and it falls over in front of us. So we're still to test with fluorescence and to see if we're cross-contaminating ourselves, but the team at Sacre Cœur is going to help us make a protocol for taking them off safely without cross-contaminating ourselves.
So we have the time for one more interesting question, which raises some interesting points that I hope I can get perhaps both of your input on. The question is it not a fact that we will all get this virus? Is it not the goal to limit the degree of viral load at initial exposure, as those with high exposure seem to have a worse prognosis? And if that's the case, is a reusable respirator mask and adequate PPE, such as face shields, hair cover, gowns, adequate from this perspective? So I guess we'll tackle the first part of the question is, what is the likelihood of contamination of the entire population with, or a significant proportion of the population with the COVID virus? I realize it's purely speculative, but can we draw examples from other countries to answer this question?
So personally, just a little side note, for myself, when it comes to influenza, for my son, again, who's a high-risk patient for any type of respiratory disease, I rely on two things. I rely on herd immunity, and I rely on vaccines. I don't want him to get it. I don't want, like, when it comes to COVID, I do not want, I know that most of the population is going to get it, so we can attain herd immunity, you know, if before a vaccine comes on. But for some people, we can't, we don't have that luxury. We need to protect our families.
Right. So having taken your remarks into account, thank you for your closing remarks, Rene. I went back to the questions. There was slightly a bit convoluted in trajectory. To our listening audience, I certainly hope that you found these presentations and the ensuing questions to be informative. I did preface this by saying that there would be some controversy in what's been presented. And as a panel, we debated the notion of this controversy and the fact that that it would perhaps ruffle some feathers and raise some eyebrows. In our disposition as an association, we're very sensitive to the fact that we defer to provincial governing bodies who have absolute jurisdiction over in dictating practice guidelines and practice conduct in our offices and standards of care. And we don't want anybody to misconstrue the information that we've shared with you today to be contradictory to that. We feel that as an organization providing information to our members, that we can provide scientific information to you on occasion, as we do at our conferences. But we can also present what we refer to as proof of concept information and interesting concepts that will force us to look at things perhaps from a different perspective. As Dr. Caissie has mentioned, we're now very much aware of, or more aware of, ventilation issues in our offices. There's been a lot of conversation on, in parallel to the discussion of presentation or preparation of this presentation, on the notion of building codes and the differences between the construction of medical facilities and the building codes that are inherent to the construction of private operating room or institutional operating room facilities versus dental clinics, which have made me personally pause on the idea that if I were going to build a clinic tomorrow, I might take a second look, a more careful look at the ventilation, with an eye to having a very good idea of what the air turnover is in my operating rooms, and if there is a potential for appropriate negative pressure ventilation in areas that require it. I'd really like to, first of all, to all of our colleagues out there, our CAOMS colleagues, we hope that you're home, that you're safe, and that you're well. And we certainly look forward to the day when we can see each other face to face on the other side of what is an ordeal for all of us. We really are interested in your feedback on this type of webinar. The CAOMS as an organization is trying to find its voice and enhance communication with its members and the professional community at large. So your feedback on these issues would be very much appreciated. I'd like to take just a second to thank all the clinicians out there who might be listening. For those of you that are on the front lines, that are working in institutions and other healthcare sectors where you are on the front line, whether you're a medical doctor, a dentist, a nurse, an orderly, or anybody else along that spectrum that's confronted with this, we thank you for the work that you're doing. It's not easy to do that and then expose yourself to those risks, and we hope that you stay safe and that you stay healthy. And I guess that's a wrap. Thank you very much for your attention and for joining us tonight. And thank you so much to our speakers who've dedicated a lot of time to being here. Thank you, Dr. McCann, for co-hosting. And thank you to McGill Multimedia for making this a much more professional type of presentation. Have a good evening, everybody.
Thank you.